Namaste, good evening, and very warm namaskar from Kolkata to all of you. Shilpa, my heartfelt thanks to you for inviting, and thanks a lot for those kind words. Um, Also, I thanked Indian Radiologist for giving me this wonderful opportunity to participate in such a mega event. The job given to me by Shilpa today is to talk on detecting and characterizing breast calcifications. Um, I'll be concentrating more on characterizing than on detecting, because I think there's probably a bit more difficult learning there. The objectives of today's talk would be that we discuss about some BIRADS 2, or completely benign or no-touch calcifications. And then we discuss about the morphology, distribution, and BIRADS categorization of the suspicious calcifications. And then we summarize some key points. Okay. Your big BIRADS talk is about to come next, but I'm just going to show the slide so that for those junior residents who are here, there's just kind of summarization of BIRADS. So, and this is important because I'm going to ask you some quiz questions now, and that involves BIRADS. So, BIRADS, can be of 6 different types, 0 to 6. 0 means that we need additional imaging, maybe an ultrasound, to decide the actual BIRADS of the lesion. And also sometimes it may mean we need old images. 1 means that it's a normal study. 2 means it is entirely benign, so nothing to be done for these 2 groups. 3 means that it is most likely to be benign, but we will still keep them on follow-up. Okay. 4 means it is suspicious for malignancy. 5 is highly suggestive of malignancy. So both 4 and 5 categories need a biopsy. And 6 is when the patient comes to you with the result of the histopathology, and it shows already, a proven breast cancer. If you try, and for those of you who are new to this, if you can try and remember that 2 is benign, 3 is probably benign, you're not worried about it, but you're keeping for follow-up. 4 is suspicious, and 5 is really suspicious, and both of these categories need biopsy to be done. And then 4 is further categorized into A, B, and C, depending on the likelihood of malignancy, the likelihood of malignancy increasing from 4A to 4C, okay? So here comes the first quiz question, and I would like to actually, start polling now, if that is okay. So you have a patient with grouped round calcification on the baseline mammogram. That means the first mammogram that the patient has had. And what categorization would it be in terms of BIRADS? Would it be, please choose A, B, C, or D?
So, ma'am, is the polling result visible to you?
No, actually it isn't.
So most of them, like around 52% are telling A.
Okay.
Option A, and 32% are telling option C.
Okay, thank you so much. I'll move on to the next question, which is segmental fine linear branching calcification. Again, the same thing, A, B, C, or D, please.
So now it's like almost divided polls, but 31% are for B.
31 is B. Okay.
Yes. And then 26% for A, 23% for C.
Okay, great. And D is 20%. Okay, fantastic. So we go to the next question, which is the last question actually.
So now 45% are with A, option A.
Okay, great. So we will come back to these very questions at the end of the talk. And we will see if we've changed in a significant way at all. So now we go on to the very typically benign lesions, which are really the touch me not lesions, because they really don't mean any harm. There are a few of them. We'll go one after the other. So skin calcifications typically occur in the sebaceous glands. They tend to be like this, with a little lucency in the center, either in the MLO or the CC, or if you've done the lateral for any reason, try and see if some of them at least are right on the skin. And you can be home and dry, for certain that these are skin calcifications. And skin calcifications are always benign. They typically occur at the axillary region because, wherever there is fold, axillary region, the inframammary fold, the parasternal area or the medial part of the breast. So they can be grouped like this, sort of small 5 millimeter groups of little calcifications with lucencies within them. These are entirely benign, BIRADS to nothing to be done about these at all. Another example, so few tiny microcalcifications, and you see here that they are actually in the skin on the lateral view. Also, if you see that the calcifications do not change in the relationships with each other in the cluster on the
Sorry, Suma, your
lateral and...
voice is breaking a little bit.
Okay. Is it better now? Is it better now?
It's saying your internet connection is unstable.
Oh, okay.
So just in case someone else is on the net, you can request them to be off the internet. Thanks.
Not really. So, can you hear me now, Shilpa?
Yes, now I can hear you.
Okay, so I'll please do let me know if there's a problem. Sorry about that. So basically, if you have the different dots within your group calcification, if they have the same relationship with each other on all the views that you've taken, then it is likely to be skin calcification as well. Then we have the typically benign vascular calcification, which are parallel lines that run through, which is arterial calcification. You can call them by different names, tram track sign or railroad sign, but they're entirely benign. Coarse or the benign coarse or popcorn-like calcifications, again, very typical of fibroadenoma, and these are benign and you don't need to do any further test. You don't need sonographic correlation either. Large rod-like calcifications like these, very well-defined edges, you can draw a line with pencil around the edges. In ductal distribution, are almost always, either or almost always due to calcification within ectatic ducts, and it could be, sorry, can you, okay. Sorry, so they basically are always benign and we do not need to do any further ultrasound or anything at all. Then we come to rim calcification, which is like a cyst whose wall is calcified. If you imagine a sphere, which is...
Sorry to interrupt, but the voice is not clear. Can you be on your hotspot, a mobile hotspot, please?
Just a moment.
Sorry about that.
No, I'm so sorry. I've never had a problem, so I'm not able to work out what it is. What about now?
Yeah, now I can. Now we can hear you.
Okay, so rim calcification is when there is calcification on the wall of the cyst or oil cyst or just a simple cyst which is over a period of time calcified, and again is entirely benign. Dystrophic calcifications are typically seen after trauma or surgery, radiotherapy, or after an abscess, and they can look pretty bizarre because these form in the stromal component of the breast parenchyma. They don't have a fixed shape. Sometimes it can be confusing very early on. They can look like fine pleomorphic calcifications. Often, if that's the case, you can keep them on follow-up, or rarely they may need a biopsy as well. But they are very typical like this, entirely benign, then nothing needs to be done. Another example of dystrophic calcification, these tend to coalesce with time and become somewhat like popcorn calcification. Milk of calcium is basically either in micro or macro cysts. If you have little calcific deposits, which when the lady stands up due to gravity, it forms a crescent and it forms, kind of settles down within the cyst. What happens is on the CC you see a smudgy calcification, not really these crescents, but when the lady stands up and you have a true lateral, sometimes an MLO as well, you can see layering of these calcifications, and these are again entirely benign in nature. Less obvious of example of this, this is layering here. Sometimes you don't see lots of calcifications layering, but you have to basically compare your CC and your ML images, and also ultrasound sometimes shows you small cysts with calcifications within. Calcification of sutures and calcification of clips like here are again entirely benign. So that comes, basically that brings to an end the obviously benign calcifications which we don't need to do anything about. If the calcifications don't look like the obviously benign calcifications, we would call this group of calcification the suspicious calcification. And there are two aspects of any calcification when we want to decide how suspicious they are for malignancy. Look at the morphology and the distribution, and that should actually complete the jigsaw for us. Okay. Before to get to that point, it is very important to check the calcification on both views. So this is part of detection of calcification. If you see a group in both views, that's a true cluster. But if you see a cluster which kind of spreads out in that area on the MLO view, you know that you're not looking at a true cluster here. So do check for calcification on both the views and try and correlate them. Like for any abnormality seen on mammography, when we see calcifications, we do a lateral view to see whether the lesion is in the upper or the lower breast, especially when it's in the nipple line. This becomes very important. We do a magnification view in CC or in lateral. So why characterize calcification? This is because in screening mammography, where we do find a number of non-palpable breast malignancies, about 41 to 47% of these are actually calcifications. Although we do not have a screening program, we do still screen quite a few women, and we also get incidental microcalcifications, which we see in our symptomatic women. So it's very important to characterize these calcifications so we know what to do with them. This diagram may come up today and tomorrow in many talks. This is the basic functional unit of the breast, the TDLU. So if you think about the extralobular terminal duct, the intralobular terminal duct, then the duct tubes, and the pink things are the acini, which secrete milk, okay? So if you can try and remember this, and then we can kind of understand where the different calcifications arise and come from. So if calcification was to occur in the acini around these, it would form tiny little round dots, which would be the round or the punctate calcifications. If it were to arise from ducts such as this, then we would have linear orientation of calcification. If it were to involve the entire segment, an entire duct with its multiple branches and the whole of this, then it would give us a segmental pattern like a tree, tree with its branches. If calcifications were to occur in the stroma, which is kind of here or here or here, where there is no particular structure within which they are forming, and they would give us some bizarre shapes, shapes which are different, and which you see. If there are 10 dots of calcification, all 10 of them may have different shapes because they're not growing within a particular part of the breast parenchyma. So this often you find in coarse heterogeneous calcifications, which tend to be stromal in nature. Now, this entire TDLU is only 2 millimeters in size. It can sometimes increase in size with sclerosing adenosis or fibrocystic disease to about 5 millimeters or so. So if you can imagine now, if the whole of this is about 2 millimeters or so, acinar calcifications, which are the punctate or the rounded calcifications, will be really, really tiny and micro, it will be micro calcifications really. So just to have a concept about what the calcifications may look like and what their distribution may be, depending on where they come from. For example, acinar calcifications are almost always benign. That gives us an idea about what the calcifications may be. So to go the BIRADS way, today we're going to learn 5 terminologies. Many of you, I'm sure, are well versed with breast imaging, and that's fine. But if there are junior trainees here who are maybe listening to a breast calcification talk for the first time, there are 10 terminologies that we need to learn today, 5 in distribution and 5 in morphology. So talking about distribution of calcification. If the calcification is seen in the entire breast, upper and lower breast on the MLO view and inner and outer breast on the CC view, it's called diffuse calcification. Like any other branch of radiology, anything that tends to be diffuse tends to be good. They're the same with calcifications. Diffuse calcifications tend to be benign. Then regionally, this means a large region, which is more than 2 centimeters in maximum dimension, with lots of tiny calcifications within it, is called regional, distribution. But a similar kind of, multiple dots close together, but smaller in size, 2 centimeters or smaller in size, is called grouped. Okay, so the only difference between this and this is the size. Regional can even involve an entire quadrant. It can be quite large. Grouped is never more than 2 centimeters. And to call it a group, we need to have at least 5 calcifications within 1 centimeter of each other. Okay. Now, then we come to segmental, which is the distribution where a duct can be involved in all its branches in this area of calcifications. The only difference between segmental and regional is that segmental is in the distribution of the duct segment. Regional has no connection or no distribution connected to the segment in which, abnormalities. Let me simplify it a bit. Segmental means the entire ductal system is involved. Regional, when you draw a line around it, it does not form a segment. When we say it's a segment, it's typically kind of a triangular kind of area with the tip at the nipple. Okay, that's how the distribution of a segment is. Regional or segmental calcification can be the same size, but the difference is the distribution pattern here, which conforms to a segment and which does not conform to a segment in regional. And then we come to linear, which we saw is usually calcification. The segmental and linear calcification are not good news. News, regional group. So if you have to look at this, different tend to be BIRADS 4. And basically, what we can see from here is anything that is not diffused. Example of BIRADS 2, as you can see, rod-like calcifications in the entire breast, and this is plasma cell mastitis, entirely benign. Another example of there is a rounded calcification and multiple tiny punctate calcifications. I don't know how well it is seen on the screen, but basically this is again benign because it's widespread, and tiny punctate calcifications from the acini, as we saw earlier. Regional calcification, there's calcification here, there's some more here, there's some more here, but it doesn't conform to a segment. This is more than 2 centimeters, and therefore it is regional. So any calcification that you see, you have to describe the distribution. Another example of regional calcification, here there's another one, there's calcification here, here, and some here as well. So more than 2 centimeters and not in a segmental distribution. Small grouped microcalcification here, which is less than 2 centimeters, and linear, which means in a line within a duct, okay, linear pattern here, and a segmental distribution, like a triangle, as we saw earlier, with the tip of the triangle towards the nipple. More examples of segmental calcification, and this is on tomo. Again, you can see there's a segment here, and this is basically not good. This is BIRADS 4C, which is a suspicious, which has a high level of suspicion for malignancy. An example of a mass here with some associated calcifications. This is calcification in linear distribution, and this is again calcification. And if you look at the whole thing, if you draw a line, it is like a segment. And basically, what I did was an ultrasound guided core biopsy, but I took X-ray of samples to confirm that I had got the calcification within it. Because although on CC it looks like it's overlapping, I put this image because it shows a segmental pattern better. On the lateral, the calcification was just at the outer edge of the mass and beyond it. So you can always take X-rays of the samples that you get on ultrasound if you want to confirm that you've got the calcification within. So that's distribution. Let's move on to morphology. Next set of 5 words or phrases. So round punctate, amorphous, coarse heterogeneous, fine pleomorphic, fine linear or fine linear branching. These show the morphology or the appearance of calcification. Okay. And again, these are all BIRADS 4. The amorphous, coarse heterogeneous, and fine pleomorphic and the linear. They're all BIRADS 4. The only morphology which is benign is round and punctate. In fact, in BIRADS, they describe round and punctate in the benign category. I have put it here because some round and punctate calcifications do demonstrate malignancy. So round and punctate basically means round dots like that you can see here very nicely in this example. Another one here. So it's called punctate if it is less than 0.5 millimeters in size, in diameter, and round if it is more than 0.5 millimeters in diameter. So these are rounded calcifications, typically acinar calcifications, very well defined, and they're almost always benign in nature. Then we go to amorphous. Amorphous means what? Hazy. So if you can see the calcifications but not see their edges very well, that sometimes so small or the edges are so hazy that you cannot demarcate them really well, that's called amorphous. Okay, that's a kind of morphology. Then we have the coarse heterogeneous. These typically occur in the stroma. So they tend to have varying shapes and they tend to be quite well defined, and they tend to be slightly larger than the other calcifications in size. And they don't have a ductal distribution usually, and they don't have an acinar dot-like distribution. So are kind of free souls in the stroma. So they can have different shapes and sizes, but quite well defined most of the time. Fine pleomorphic. Now, these are bad categories now we are coming into. Fine pleomorphic is very small in size, varying sizes, pleomorphism meaning varying shapes. So some are arc-shaped, some are dot-like, some are a little bit more linear, and they're very small in size. And these are, still BIRADS 4. But, the only difference between this and the next one is that we don't have the linear or fine linear branching calcifications that we have in this last category, which is BIRADS 4C, which means it is on its own a very high risk calcification to have in the breast. So if you see the V's and the Y's within the calcification, if you see here, they're similar to the branches in the trees. That means that this is definitely ductal calcification, and the Y's and V's show, kind of prove beyond any doubt that these are ductal and they are traveling along the duct. And this is in terms of morphology, the worst type of calcification. Also, if calcification is associated with the mass like it is here, which looks worrying, then you have to consider the calcification is malignant. Similar here, some coarse heterogeneous and some fine pleomorphic calcification in a large area, which is all abnormal and malignant. Associated architectural distortion, like we have here, is again, a sign of malignancy. Here again, we have very fine pleomorphic calcification, but retracted breast parenchyma, which is a type of distortion, and this is again malignant in nature. Just to put in a word about metastatic carcinoma, which is obviously not the common type of breast cancer, but we do see them rarely. The calcification here within the mass looks almost like a periosteal reaction which you would see in bones. Fluffy, especially at the edges. And when you see things like this, we have to think about whether there is ossification rather than calcification going on, whether there is an osteoid matrix there laying down bone, and we have to think of metaplastic breast carcinoma. Once we have worked out the morphology and the distribution, we then give it a BIRADS categorization. Everything that is not on the slide is 4 or 5, which means that needs biopsy. So I have put on this slide what you must remember to know as to what is 2 and 3, because the rest is easy. They're all 4 or 5 and you need to biopsy. So round and or punctate morphology, which is a diffuse distribution pattern, is always BIRADS 2. No need to biopsy, no need to worry. The skin morphology, which is regional, also tends to be BIRADS 2, but I would say you should go on a case-to-case basis and just be 100% certain. It is not like diffuse, which is definitely benign. You have to kind of keep an eye on this regional, but it is likely to be benign, more likely to be benign than malignant. Grouped baseline mammo, which means for the first time the patient has had a mammography done, there is no previous to compare, you find round punctate morphology in grouped distribution, that is BIRADS 3. Very important to remember that this is the only classification which is BIRADS 3. Everything else is either 2 or 4 or 5, but this grouped baseline mammography showing round or punctate classification is BIRADS 3. Then we have amorphous diffuse distribution of amorphous calcification, especially if it's bilateral, is always BIRADS 2. With coarse heterogeneous, if you see lots and lots of little groups of coarse heterogeneous calcifications in both breasts, they tend to be within multiple fibroadenomas or within multiple areas of fibrosis or stromal sclerosis, and they are benign as well. So the only calcifications in the suspicious category, which are benign, are round punctate diffuse, also regional, amorphous diffuse, and coarse heterogeneous numerous bilateral groups. The only three is round punctate groups. Okay, everything else comes as four, 4 or 5. For those of you who want to further categorize, there is a nice paper by Clark et al. In AJR, where they have a kind of summarized. I've basically copied the table from them, where they say how to categorize punctate. If it's it's grouped. See, grouped baseline on the first mammography is follow-up. But if you have a baseline mammogram and this grouped punctate calcification is increasing, or you find new ones appearing, it is category 4A and you have to biopsy it. And all the others, you have to biopsy it, whether you call them BIRADS 4 or BIRADS 5. The only ones which are really BIRADS 5. So there is no one morphology or distribution feature which makes it BIRADS 5. But a combination of worst morphology and the worst distribution gives a category 5. So that is the fine linear branching pattern with either segmental or a linear distribution pattern. This gives us a category 5 in terms of calcifications in the breast. Okay, so further characterization, of course, we have to do either a stereotactic biopsy in a sitting position like this on a chair, or a prone table like this, using a 14 gauge or a WAB biopsy gun. If you're doing very small groups of microcalcification, then WAB is better. Also, if you've had an indeterminate report from a 14 gauge, then WAB is better. So either using 14 gauge or WAB, and then must X-ray the specimens that we get, because that's extremely important. If you don't get adequate calcifications, that means we haven't sampled the lesion enough, because this is part of our characterization of the lesion. Okay. In general, forgetting BIRADS for a moment, if you have calcifications in the breast which are multiple, diffuse, bilateral, and morphology looks not suspicious, then they tend to be benign. On the other hand, if you have a bad distribution pattern, like segmental or linear distribution, bad morphology, like fine linear or fine linear branching, small microcalcifications, and calcifications are basically, kind of called microcalcifications if they're less than 0.5 millimeters in diameter. If there is a variation in shape, variation in size, if the individual particles, so when you do the magnification view, we've got to look at the individual particles. If these individual particles have irregular margins, the entire area of calcification has irregular boundaries, then it tends to be malignant. So it's not just about what BIRADS is it. It's also important parallelly to be thinking, is this benign or is this malignant? Is ultrasound useless? Not really. So there is segmental, fine linear, maybe linear also calcification here. On ultrasound, we see a large area of heterogeneous abnormal ecotexture with calcifications within it and increased vascularity. So large areas of microcalcifications are almost always seen in ultrasound, but very small groups of microcalcifications are extremely difficult to see. And there are some algorithms which do enhance the calcifications, but not everybody has that, but they are useful. If you have, as you can see in these pictures, you can see the calcifications much better. This is a case I had last week. This is a lady who's close to her 60s with segmental calcification. But when you look at the calcification, it's really almost rod-like and not, sort of microcalcification as such. She had a palpable mass, which was all of this, which is an asymmetry when compared to this side, which she was convinced was growing over the last 1 year. So what did we do? We compared, first of all, with 2018, and this has increased. This asymmetry hasn't increased much. Also, although she said that her mass is definitely enlarged since it wasn't there in 2018 according to her, but it appeared a year ago and it's been increasing. And calcification is increased over a period of time. And so what do? We do an ultrasound. So that's very important to keep in mind. You have to do an ultrasound to correlate things. Very benign looking parallel mass, almost looks like a hematoma, or an area of maybe even dense, fibrous tissue, and some margins are indistinct, but overall a very benign looking thing with calcifications, normal vascularity, low elasticity value, and basically lymph nodes with a little bit of thin cortex, but kind of not focal bulges, and a very benign color flow pattern. And this actually on biopsy came as stromal sclerosis. She is going to have the tumor out because she thinks it's very big and it's enlarging, but then this is a completely benign lesion. So very important to have ultrasound to correlate. I did the ultrasound, but I did again the ultrasound, I did biopsy, but again I did X-ray of the sample to confirm that I had got enough calcifications in my sample. We go back to the quiz and the poll, and I would like to see if the answers have changed now, please. So could we have a poll here? This is the first one.
So, ma'am, again, 44% are for C and 41% are for A.
Okay, so it has to be C, isn't it? Because grouped round calcification on baseline mammogram. This is the only thing which is BIRADS 3 in calcifications on mammography. So 44%, well done. That is the right answer. Okay, so we move on to the next question.
So, ma'am, 40% are for D, the last option, and 38% for B, second option.
Okay, so the B and the D, overall it's not bad because irrespective of what you choose, it's biopsy. So the patient is not being harmed, by choosing either this or this, you need biopsy. But the correct answer is actually BIRADS 5. Segmental is the worst, distribution pattern, and the linear branching is the worst morphology that you can have. So the very bad or the worst morphology and the worst distribution adds up together to make it BIRADS 5. Okay, so we'll go to the next one, the last question now.
So for this, ma'am, 85% are for A.
Oh, fantastic. So that is the correct answer, isn't it? So multiple bilateral groups of coarse heterogeneous calcifications, they tend to be fibroadenomas or they tend to be areas of fibrosis. Fibrosis is called as stromal sclerosis by some, area of fibrosis. Different people call it by different names, but basically fibrosis or stromal sclerosis. So that is really good. So that I'm very happy because both the second and the third question, I think that was very good. So we come to the quiz, and I'm just going to leave you with 2 or 3 summary slides. Distribution, diffuse, regional, grouped, linear, segmental. This is the most favorable, diffuse, and this is the least favorable. Segmental and the linear are the least favorable, okay, in terms of distribution. Morphology, again, round punctate is the most favorable, whereas the fine linear or fine linear branching is the least favorable classification type that we see on mammograms. Okay, and again, if you remember this slide, if you have a round or punctate, diffuse or regional, then in diffuse regional distribution, it tends to be BIRADS 2. Grouped on baseline mammogram tends to be BIRADS 3. Amorphous diffuse and coarse heterogeneous, numerous and bilateral is 2. Everything else is 4 or 5. So everything else needs a biopsy. And that's it. We come to the end of our talk. And thank you once again, Shilpa. And thank you once again, Indian Radiologist. And thank you once again, the lady or the doctor with the sweet voice who did the polling. I don't know the name. Thank you so much for helping me through this.